So good evening, my friends. We are going to start the session that we took partway through yesterday on the live class. So this one is going to be the online live class now. So the topics that are left behind are salivary glands and the oral cavity lesions. So let's start off without much ado. Regarding ranula and plunging ranula, which is the false statement. Ranula is a mucus extravasation cyst of the sublingual gland. Plunging ranula is a mucus retention cyst of the sublingual gland. Plunging ranula needs excision through a cervical approach. Ranula needs excision or a less invasive approach to the sublingual gland. Which do you think is the false statement here? Yes, I can see that Julie and Pradeep, both of you have got it right. It is C. Plunging ranula does not need an excision through a cervical approach. So when we talk about the sublingual glands, so we have the multiple ducts of Revenus that are going to drain the sublingual glands. So each of the salivary glands has got a duct. The duct of the parotid gland is known as the Stenson's duct. The duct of Warthin drains the submandibular gland, and for the sublingual glands, you will have multiple ducts which are known as the ducts of Revenus. Now, the two types of swellings that develop from a sublingual gland are, one is the mucus extravasation cyst with a characteristic translucent swelling that happens in the floor of the mouth. So that one, what we have, that is known as the frog's belly appearance, which we saw in the first picture. This picture, what we can see here, this is a ranula that we see. So it is a swelling that develops in the floor of the mouth area. So it's a mucus extravasation cyst. For those of you who want to understand what is an extravasation cyst versus a retention cyst, an extravasation cyst drains against gravity. So there is some active, mechanism which is going on, whereas a retention cyst is going to be just passive due to blockage. So what happens initially in a ranula is it is an extravasation cyst. It develops as a swelling, usually leads into the floor of the mouth. So when you have the swelling, you cannot just do an R&D. You will have to plan for resection of the submandibular of the sublingual gland. Only then it is going to get treated. The same way, if you take a plunging ranula, what happens is that goes on to develop a, what you can say as a swelling that extends into both the neck and into the oral cavity as well. So it crosses the mylohyoid. So anyone who have questions, kindly type it in the chat box. I have the chat box in front of me. So Redmi IC has raised a hand. Please type the questions here to keep up the flow. I will answer the questions one by one. So what we have here, this is the kind of presentation that we'll have: a cervical swelling with an intraoral swelling as well. So both of this will be seen. This approach that we have to do is not actually a cervical approach. The cervical approach will be contraindicated. The diagnosis will be by ultrasound and by doing an MRI, which will clearly show the lesion in both in the oral cavity and also extending across the mylohyoid into the neck as well. So the excision of such thing, the approach via a transcervical approach is going to be contraindicated. What we have to do is we have to do a surgical removal of the sublingual gland, and we have to aspirate the secretions, and whatever sac that is left behind will collapse by itself because it is only a connective tissue covering that comes as a reactive thing there. So that is the way you have to approach it. Now, as far as the malignancies are concerned in the minor salivary and in the sublingual glands, so the highest risk of malignancy will be in the minor salivary glands tumor. Some people include the sublingual gland also under the minor salivary glands. Even if you don't include, still, if you take up the numbers per se, you will find that around 90% to 95% of minor salivary glands tumors are going to be malignant. And the same thing as far as the sublingual is concerned is going to be 85 to 90%. So whenever you have a tumor of the sublingual gland, you will plan for a wide excision, and most cases will actually remove the mucosa as well, and along with the mucoperiosteum whenever you suspect a kind of a malignancy. And the reconstruction will also be needed by a radial phenom free flap, or in some cases you may need a fibular free flap as well, depending on whether the patient has got a extension onto the mandible or not. And adjuvant treatment will be needed. The indications for adjuvant RT will be dealing with when we are talking about the other tumors of the salivary gland. So this is how a plunging ranula and a ranula will look like. You may get a exam question as a what you can call as a pictorial question, and they may be asking what is the approach and all that. So this is going to be the management, and that is the approach that you will have. Now regarding Sialolithiasis, which is the false statement, 80% in the submandibular gland, of which 80% are radiopaque. Most common is in the hilum or in the papilla. Less than 4 millimeter need a Dormia basket. Larger stones need intracorporeal or extracorporeal shockwave lithotripsy. Mealtime syndrome is associated with sublingual Sialolithiasis, which is the answer here, which is the false statement here. Okay, so you can see many of you have answered correctly. Answer is D. So 80% happen in the salivary gland in the submandibular. Of all the areas where you can get a sialolithiasis, submandibular glands are the ones which are most commonly involved. Some of the reasons which are told are highly mucinous secretions that come, anti-gravity drainage which is there. These are some mechanisms which are put forth for why the submandibular gland is commonly involved in sialolithiasis. And many of these stones will also be radio opaque. And when you look at it, you can see the picture there. If you look at it, you can see the tumor which is going to be sitting here. Not the tumor, sorry. You can see the stone which is going to be sitting here at the papilla. That is one common location where you have the opening. Just underneath the frenulum, on either side of the frenulum of the tongue is where you will have the opening of the sublingual of the submandibular glands. And at that area, at the papilla, is where you will usually get a blockage of the stone by the duct. And the other one is going to be in the hilum, where the submandibular duct is going to form or take its origin. At that part, you can have the stone. So these are the two locations where you will commonly develop a stone. And submandibular glands in general, their relation is mainly with the facial vessels, and along with that there are going to be a few nerves which are related to it. The most important nerves that are in relation to that are the marginal mandibular nerve, the lingual nerve, and the hypoglossal nerve. All three nerves are going to be in relation to the submandibular gland. Plus you're going to have the mylohyoid muscle, which essentially the tumor is going to, the gland is going to wind around. Suppose this is the mylohyoid muscle, the gland will be winding around the posterior surface of the mylohyoid muscle, and the part which is deep to it is known as the deep part, and the one which is superficial to it is known as the superficial part of the submandibular salivary gland. So Warthin's duct, which starts from the deep lobe, will drain on either side into the papilla. Now, if you take up the ectopic location, this can come again as a picture question. What is represented here? Ectopic bony location, the Staphy's cyst. This is the commonest location of an ectopic or aberrant salivary gland at the angle of the mandible. Management is just observation, nothing needs to be done for it. Sialolithiasis usually due to bumps, most common in the parotid, rarely can involve the submandibular gland as well. Now, sialolithiasis, which we are discussing, 80% is going to be there in the submandibular salivary gland, and 80% are going to be radio opaque. Commonly, you will get the phosphate or oxalate stones. Now, when you take up the other two choices which were mentioned for the management of the tumor, for small tumors, whenever you have for small stones, not tumors, sorry, when you have small stones which are less than 4 millimeter, you can do a Sial endoscopy and a Dormia basket retrieval. Now, this is something which was new to me. This is all there in Bailey, no big book. It is all there in Bailey. If you look at it, no other book actually gives you a perfect thing like Bailey. Okay, so among the textbooks that you read, as far as salivary gland is concerned, Bailey gives a very good picture of everything. Okay. One second, guys. Yeah. So among the stones, when you have a 4 millimeter stone or less, then you have to go for Sial endoscopy and a Dormia basket retrieval. This is going to be done for stones just like what we do in the renal system as well. Whenever you have a ureteric stone, you will go for ureteroscopy and Dormia basket retrieval. The same thing can be done here for the small stones when they are present in the submandibular salivary duct as well. When the stones are larger, then the same way we can do an intracorporeal or extracorporeal lithotripsy, and 70% of the stones will get cleared in this way. Only when they are large stones which are not getting cleared either by lithotripsy or by extraction, only in such cases we have to go for surgical removal of the stone by itself. So the most common site of obstruction, as we already saw in the previous picture, it is in the hilum and in the papilla. Now, what is this mealtime syndrome? Essentially, whenever there is a blockage of the duct by the stone, there is going to be stimulation of salivary secretion when the person is going to have a meal. So at this time there will be excess salivation which will get stasis. There will be a lot of stasis inside the gland, and this will swell up, and this leads to development of the mealtime syndrome, where there is acute swelling, pain, and this will get sometimes relieved when when there is a jet of saliva that comes through pressurizing on either side of the stone. But otherwise the stone will just keep increasing. This will lead to repeated attacks of sialolithiasis, and finally the patient will need surgical removal at some point of time or the other. Now, tumors of the submandibular, tumors of the salivary gland, which is the false statement here. 50% of submandibular tumors are benign. 85 to 95% of sublingual and minor salivary gland tumors are malignant. Adenoid cystic carcinoma is the most common submandibular tumor. Adjuvant radiation is indicated for close margins, size more than 5 centimeter, and high-grade tumors. Which is the option here? Which is the false statement? Okay, I'm seeing C, D, A, one more C, Gaurav, Bharadwaj. Okay, so many of you, Gaurav, Bharadwaj, Habiba Ali, Vijay Chaudhary, all of you have gotten it right. So this is the correct answer. So adjuvant radiation is indicated in close margins when the size is more than 4 centimeter, not more than 5 centimeter, when the size is more than 4 centimeters, and in high-grade tumors. All the other statements here are absolutely correct. So when you take up the salivary gland tumors, especially the submandibular tumors, it is a 50-50 distribution. In Bailey, at 2 places, it will be mentioned as 60 to 70 and 50 to 50. But in general, most of the textbooks will give it as only 50%. So for the exams, you can remember it as 50% benign, 50% malignant. So generally speaking, the larger the size of the gland, the lesser will be the chance of malignancy. So when you have a tumor in the parotid gland, there is only a 20 to 25% chance that it will be malignant. So in Sebastian, it will be given as 25%, 50%, and 75%. But you can follow Bailey. You can remember it as around 20% of parotid tumors, around 50% of submandibular tumors, and almost 80 to 90% of all the minor and sublingual salivary tumors are going to be malignant. Now, if you take up high-grade tumors, usually they will be having a rapid growth associated with facial nerve involvement, and along with that, the skin over the parotid area is going to get infiltrated. Plus, there is a high likelihood that they may have cervical nodal metastasis as well. Now, in the submandibular and in the other minor salivary glands, the most common tumor is the adenoid cystic carcinoma. Overall, the most common carcinoma, we will come to that when we are dealing about it in the parotid gland. Now, how do you manage these tumors? Whenever you have a salivary tumor, you have to go for an FNAC. Rarely you may go for a true cut. Preferred is always an FNAC to establish the diagnosis of malignancy. And once that is done, then you have to go for a CT scan or an MRI of the leg. Now, what is this picture which is displayed here? You can see the diagram which is displayed here. Can someone tell me what it is first? What imaging modality it is? Anybody? What imaging modality is this? Okay. So except for Mohak, all of you have gotten it right. So this is a CT scan of the head and neck area in the submandibular region especially. Now what do you see here? What is the white arrow which is pointing there? What can you see there? What is the diagnosis? Can you tell me some description of this particular thing that you see here? What is pointed out by the white arrow? Can someone give a description here? Okay, it is hypoechoic. Now, the term hypoechoic is something which will be used only in an ultrasound. So I'll just go through the normal structures first. What you have here, where my black arrow is pointing, that is your mandible. That is the mandibular arch that you have there, and you can see the bellies of the digastric here. Okay, so this is the belly of the digastric. But otherwise, this is definitely not a parotid tumor. This is a submandibular tumor only. So you can see that there is a large swelling in the left submandibular area. Now, this side, what you can see here on the right side, that is a normal submandibular gland. And what you can see here is the hyoid bone. What you can see here in the midline is the hyoid bone. And this part, what you can see, 2 structures on either side, this is your vallicula. You can see that, and this is going to be your pharynx. So that is near the base tongue area. That is why you are able to see the vallicula. That is where the cut has been given here. Okay, so now if you look here, this is the area where you have the right submandibular gland, which is normal. This is the left submandibular gland. As someone has mentioned, there is a lot of necrosis which is going on, pretty much a solid tumor with central necrosis, shaggy edges. The edges are quite well demarcated. It doesn't seem to be infiltrating into any of the structures here, but then you can see that there is a large swelling which is sitting there with some necrosis inside. This is likely to be a malignancy. We don't know for sure, but this is likely to be a malignancy. This is how it will present as a large tumor, and on a CT scan, this is what you can look at. Okay, this is what you will find. So as I already told you, as far as the tumors are concerned, if you take it up, 50% of submandibular and 85 to 90% of the minor salivary glands are going to be malignant, whereas in the parotid, it's going to be only 10 to 20%. So in the salivary glands, the most common tumor overall, if you look at the malignancy, the answer is going to be, what is the most common salivary gland malignancy? No, no, no. I'm talking about adenoma. I'm not talking about adenoma. I didn't ask you about tumor. I said, what is the most common malignancy? I didn't ask about what is the most common tumor. If the answer were most common tumor, then that is the answer which will be correct. Yes. So many people have started messaging here. So answer is correct. It is mucoepidermoid carcinoma. That is the most common malignancy of the salivary glands. But if you take up the minor salivary glands, including the submandibular salivary gland, the most common malignancy is going to be the adenoid cystic carcinoma. So if you look at it, MEC is the most common salivary malignancy overall. And also, if they ask you parotid specifically, then MEC is the most common. Second most common is going to be your adenoid cystic carcinoma. But if you take up minor or submandibular or you take up your sublingual, then the most common is going to be adenoid cystic carcinoma. Okay, so that is why in your submandibular, it is going to be your adenoid cystic carcinoma, which is the most common malignancy. And for this, the management is again going to be similar. You do an FNAC. Suppose you have got this tumor like what we have gotten here. So you will do an FNAC. This will be a swelling which will be quite apparent from outside. So what is going to be the characteristic clinical feature which you will get in a submandibular tumor? Clinical finding, clinical what you can say as a sign that you can elicit in a submandibular tumor. Yes. So bimanual, or rather you should call it as a bi-digital palpation. So where do you palpate? Where do you put the bimanual? I mean, where do you put the two digits? Intraorally, where? Oral cavity and neck is fine. That is very clear. Yes, floor of the mouth. Dr. Bashir is right. So that is the answer that I was looking for. So one is going to be the FOM and the other one is going to be in the neck. So that is the answer that I am going to look for. So floor of mouth, you put one finger, the other finger here. This is especially for smaller tumors. Larger tumors like this will be very apparent. Even open the mouth, the bulge in the floor of the mouth will be seen. For smaller tumors, you do a bidigital palpation, then you can find out the salivary gland, which is going to get enlarged in that area. So after you do that, then you can do a FNAC of the tumor, and then you can establish the diagnosis, do a CT scan, find out if there are any metastases, and establish that there is none. And after that, you can proceed with the management. The essential management for this is going to be a submandibular salivary resection with the level 1, 2, 3 neck dissection usually, because submandibular gland, because of its sheer location, you will have to clear the level 1, 2, 3 nodes. The main things that you have to look out for, as I already said, the structures which are in close relation are going to be the marginal mandibular nerve. Then you are going to have your hypoglossal and your lingual nerves. All three you should look for and preserve at the time of your surgery. And there is a particular maneuver which is mentioned here called as the Hayes-Martin maneuver. What is this Hayes-Martin maneuver? Can anybody tell me what is the Hayes-Martin maneuver which I have underlined here in the slide? Yeah, to prevent injury to the facial now, but how do you, to the marginal mandibular, but how do you prevent that? Elevating the flap, how? See, essentially what you do is the facial artery and vein. These two are ligated and pulled up. So you have to ligate the facial artery at the lower border of the mandible. and then you pull it up, and that is where you will identify. So you have to ligate the facial artery here and then pull it up, so that will kind of make the marginal mandibular go up, and that way you can avoid damage to the marginal mandibular now. So that is how you can prevent the injury. So this maneuver is known as the Hayes-Martin maneuver. He was one of the pioneers of neck dissection, and this is an essential step during neck dissection and during submandibular gland surgery as well. So once you have done the surgery and you have removed the tumor, including plus or minus the neck nodes if they are going to be enlarged, then you have to plan for adjuvant treatment based on the histopathology. Whenever you have a tumor which is more than 4 centimeter, when you have high-grade tumors or when the margins are close or involved, then you'll have to plan for radiation. So these will be the indications for radiation therapy. One other indication that you have to remember is the presence of adenoid cystic carcinoma. So most common nerve injury, I guess, which is there in submandibular gland surgery, I will probably say is the marginal mandibular nerve. Okay, it's the marginal mandibular nerve which will be most commonly involved. Hypoglossal and hypoglossal and lingual nerves are rarely affected. It will be the marginal mandibular nerve which will be most commonly injured during your submandibular gland surgery. So other than close margins, size more than 4 centimeters and high-grade tumors, you have to remember that presence of LVSI, presence of PNI or perineural invasion, lymphovascular space invasion, presence of adenoid cystic carcinoma. Whenever it is an adenoid cystic carcinoma, always we have to go for adjuvant radiation. Why? Why do we need radiation in terms of treatment in adenoid cystic carcinoma? Yes. So perineural invasion and skip metastasis. So the PNI and skip lesions are very common as far as your adenoid cystic carcinoma is going to be concerned. So because of this, always radiation is a part of treatment whenever the diagnosis is going to be an adenoid cystic carcinoma. Right. Parotid tumors, which is the false statement here. Second most common malignancy is adenoid cystic. Adenocarcinoma is a low-grade tumor. Most common site of salivary tumors is parotid gland, and B-cell NHL is the most common lymphoma in the parotid gland. So which is the false statement here? So Ankit has typed B, Julie also says B, Abiba says B, Subodh says D. Any more answers? Okay, so most of you have gotten it right. B is the correct answer. So when you take up parotid tumors, the most common location of parotid tumors is going to be in the, salivary tumors is going to be in the parotid gland. And the most common tumor is going to be the benign pleomorphic adenoma. 80 to 90% will be benign as far as the parotid is concerned. And as we already discussed, the most common malignancy is mucoepidermoid, and second most common is going to be adenoid cystic carcinoma. Now, when you take up the high-grade carcinomas, you have got squamous cell carcinoma, high-grade mucoepidermoid, and the adenocarcinoma. Now, what are the low-grade carcinomas? You can have the low-grade mucoepidermoid carcinoma, and you can have acinic cell carcinoma. These two are definitely low-grade. Now, adenoid cystic carcinoma is something which is, kind of, whenever we talk about adenoid cystic carcinoma, generally we talk about PNI. But whether the grade is high or not is something which is not known, because it is usually an indolent tumor. You will get lung metastasis also in case of adenoid cystic carcinoma, but still have a long survival. Still OS will be long as far as your adenoid cystic carcinoma is going to be there. So this kind of presentation doesn't really make it a high grade tumor, but in Subiston it is mentioned as high grade. In Bailey it is usually mentioned among the low grade tumors. But one thing you have to remember is either way, whenever you have adenoid cystic, we have to go for adjuvant radiation therapy because of the presence of perineural invasion. But the name types like your mucoepidermoid high grade, squamous cell, and adenocarcinoma, all these three are going to be the high grade tumors. There is no doubt with regard to that. The investigations are preferably an MRI. CT can also be done, but MRI will give you a much more better picture as far as the soft tissues are concerned. So as far as parotid is concerned, MRI is preferred, and initially you will do an FNAC. Sometimes you may need a true cut, and that is how you will go about with the management. A CT chest will be done if the diagnosis is suggestive of a malignancy to rule out any metastasis, and clinical examination and plus your CT or MRI will tell you about the neck nodal status. So once you have established the diagnosis and you have done your surgery and you have done your metastatic workup as well, if it is non-metastatic, then you will plan for surgical resection. Now the management is going to be, whenever you are going to have a superficial lobe tumor, what is going to be the management? Malignancy of the superficial lobe alone. What is the management? Is it superficial parotidectomy, total conservative parotidectomy? radical parotidectomy, what is going to be the option? Yes, so generally for malignancy, you will talk about the total conservative parotidectomy. Okay, but in today's world, they also say that you can do an adequate parotidectomy. An adequate parotidectomy is also something that can be done as far as management is going to be concerned. But for your exam, you can remember it is going to be TCP. You can mark it as total conservative parotidectomy. Suppose you have a tumor in the deep lobe. Let us say you got a pleomorphic adenoma in the deep lobe. What is the management? Pleomorphic adenoma of the deep lobe, what will be the management? Yes. So whenever you have a deep lobe tumor, even the approaches, you don't need to do a radical parotidectomy. Only if the nerve is involved, you have to do a radical parotidectomy. In general, the option is still going to be for any deep lobe tumor, it is going to be a total conservative parotidectomy. There is nothing called as a resection of the deep lobe alone. Whenever you do a surgery for the parotid, to reach the deep lobe, you'll have to remove the superficial lobe, identify the facial nerve branches. It will be like this, the pes anserinus. So you will have to kind of lift up the facial nerve branches, then go deeper to it and then remove the tumor. So whenever you have a deep lobe tumor, the management is minimum will be a total conservative parotidectomy. So when will you remove the facial nerve? So facial nerve resection or a radical parotidectomy, as it is called as radical parotidectomy. What is the indication? When will you do a radical parotidectomy? Yes. So in a sense, unless the nerve is clinically involved, so you already have a facial nerve palsy, only then you will consider removing the facial nerve. So only when you have a facial nerve palsy already existent, then only you will go for a removal of the facial nerve. Otherwise, the facial nerve is always bad, even if it means it is an R1 resection. Suppose you have to go a margin positive resection, still you will preserve the nerve. This is the general dictum as far as most major nerves are concerned. Whenever you have the nerve, unless the nerve is completely encased. So they may use some terms which may confuse the issue. So when you have a nerve encased by tumor, when you see the term encased by tumor, then you will have to do a radical resection. Okay, so if the term which is used is encased by tumor, if they have used that, then you will have to go for radical resection. In adenoid cystic carcinoma, even though you may have PNI, you will go for only adjuvant radiation. You don't need to resect the nerve. There is no need for nerve resection as far as adenoid cystic carcinoma is concerned. Right. So at the time of parotid surgery, all of us know the main challenge is going to be the facial nerve identification, for which you have multiple techniques. So the common things which will be asked are, one is going to be the tragal pointer. You will have the tragal pointer, which will be, once you see the Conley pointer, which is identified the cartilaginous and bony junction, that is where you will have it. So at that junction, if you look at it, the facial nerve will be 1 centimeter inferior and deep to the tip of the Conley pointer. It's 1 centimeter inferior and deep to the tip of the Conley pointer. The other way you can identify is look for the posterior belly of digastric along the upper border. You can go for mastoid drilling in some select cases. Styloid process can be used. Squamotympanic fissure. There are multiple approaches, but the only question clinically which is going to be there is going to be the tragal pointer, which will be 1 centimeter inferior and deep to the tip of the tragal pointer. Now, as far as the branches are concerned, all the branches except the buccal branch needs to be reconstructed if it is excised. So the buccal branch alone, if it comes, reconstruction is not necessary. So which is the nerve which is preferred for reconstruction? This is another question. Reconstruction of facial nerve. What is the preferred nerve which will be used? So yes, so most of you have got it right. Redmi K20 Pro, no, it is not the sural nerve. You can use the sural nerve also, but you will use the greater auricular. Why do you prefer the greater auricular? Why not the sural nerve? Sural nerve is also equally effective, but why do you prefer the greater auricular nerve? Yes, it is in the same field. You don't need to put a separate incision and take it from the neck. It is in the same field, right along the anterior border of the sternomastoid. You will get the, the greater auricular nerve. So mostly the greater auricular nerve will be the one which will be used for reconstruction, if at all it is needed. Right. Now, if you take up the surgery for the salivary glands, for the parotid tumors, Conley pointer, which is the true statement here. Conley pointer, facial nerve is 1 inch deep and inferior to it. Extracapsular parotidectomy is a recent standard for benign tumors. All branches need cable grafting after resection. Recurrences are higher after extracapsular parotidectomy, which is the true statement here. B, B, A. Okay. Ankit is in a little bit of a hurry, I think. So is Praveen 4S, Rachi. Come on, guys, you can't answer A. We just now saw A is 1 centimeter. It's not 1 inch. Read the answers properly. Don't be in a hurry. On the pointer, facial nerve is 1 centimeter, not 1 inch deep. It is 1 centimeter inferior and deep to it. So extrapaxillary parotidectomy is the recent standard of care for your benign parotid tumors. And all branches of the facial nerve do not need cable nerve grafting. We just saw that the buccal branch does not need grafting. And recurrences are less common after a extracapsular parotidectomy. So this recent technique, which is given in detail in Bailey. So what essentially happens is whenever you have a tumor, you can go for the traditional superficial parotidectomy. The incision is called as the Blair incision or the modified Bailey incision. If you look at the tragus, this is how the parotid will be sitting, the tumor. You will mark an incision along like this, and then you will go behind and then come on to the neck. This incision is called as the Blair incision or the Bailey incision. Okay, the modified Blair incision or the Bailey incision as it is called as. Now, when you are doing normally, you know how you will do. You will just put this incision, you will raise the SMAF, the submuscular layer in the face, you will just raise it in that area. And then once you have done that, you will identify the tumor, you will go all around the tumor, and then you will resect the entire parotid gland, which is superficial to the facial nerve, which is the superficial lobe. And that plane, what is that plane called as? What is the plane of the, yes, the fascio-venous plane of Patty. Okay, the fascio-venous plane of Patty. That is the name for it, the Patty's plane or the fascio-venous plane of Patty. That is the plane where you will have the differentiation between the superficial and the deep lobe. Now, when you are operating on patients, what you will do is there is another technique which can be done in today's world, which is known as the techniques. Now, this is the suppose the superficial lobe is there. Suppose the tumor is going to sit here. What you do in an extracapsular parotidectomy is you make a cruciate incision. Just 1 second, guys. Let me draw this again. Suppose this is the parotid gland tumor. Whenever you are going to excise it by extrafacial or extracapsular dissection, what you will essentially do is you will make a cruciate incision on the surface of the gland. Now, let us say the actual parotid tissue somewhere like this. And whatever I have put here in the center is going to be the tumor area. Now, you will make a cruciate incision, and then using blunt scissors, you will keep on going till you go 1 centimeter beyond the tumor. And then you will excise this particular area. 1 centimeter beyond the tumor, you will go and excise that area. Then whatever cruciate tissue you have raised, you will put it back and then you will close it. Okay, so this will be like a cross. So suppose you have the cross like this, the tissues will be taken off like this. It will be peeled away. Imagine you put a cross cruciate incision, the 4 edges you can separate. And once you visualize the tumor, you go beyond by 1 centimeter and take it out completely. It is something like a not really a shelling out of the tumor. It is more like you don't you go 1 centimeter beyond the tumor in all dimensions and then you take it out. And after you have done it, you just close it back. The advantage when you do this is, see, once you have made this cruciate incision, then you will peel it back. Okay, each one will go in one direction. This one will go in this direction, this one will go in this direction, and then you will access the tumor. And once you access the tumor, you will go, cruciate incision is given on the surface of the parotid. Suppose you have a tumor here, you will make a cruciate incision. And once you make the cruciate incision, you raise the flap like usually, but once you see the parotid, the tumor will be at a slightly deeper level. So you make a cruciate incision in the parotid, lift up a bit of parotid tissue, leave the rest of the parotid tissue along with a bit of tumor, go 1 centimeter beyond the margins of the tumor, then you lift out the tumor completely. So once you have raised this parotid tissue along with it, then you bring it back and you close it in the center. That is known as your extracapsular dissection. Okay, so when you're doing an extracapsular dissection, the advantage is, that is, look at the recurrence rates on comparison. If you look at the recurrence, it is only 1 to 1.5% as compared to 2 to 2.5% in a superficial parotidectomy. The second thing is the facial nerve injury is almost one third. Here it is 7% and here it is 25%. And Frey syndrome is zero. Most important thing is you don't get any Frey syndrome whenever you do a cruciate incision, because you're going to put back the salivary tissue there. And that is the reason why you prefer to go for this extracapsular dissection as the treatment of choice, especially for benign tumors. Of course, whenever you have a malignant tumor, you cannot use this. This is only for benign tumors of the parotid, right? So radical parotidectomy, where you will do when you get a high-grade tumor, infiltrative resection of the facial nerve, and then you will put a reconstruction with the sural nerve or with the greater auricular nerve, and usually you will also go for a neck dissection and removal of the masseter as well. So which is the false statement with regard to Frey syndrome? It is due to aberrant preganglionic innervation of the auriculotemporal nerve fibers. Starch iodine test is used to identify the tumor. Can be prevented by sternomastoid or temporalis flap interposition. Most effective treatment is Botox injection. Why is A wrong? Most of you have gotten the answer already. Why is A wrong? Yes. So the answer is postganglionic fibers. So postganglionic innervation is going to be the one which is going to be effective. So what happens is you have got the auriculotemporal nerve which is going to supply all the fibers to the parotid gland. Now, when you do a parotid surgery, what essentially happens is the fibers are going to get disrupted, and instead of the fibers that grow onto the parotid area, they will go on to the skin on the top of the parotid. So whenever a patient is going to have food after surgery, at that time, instead of stimulating the salivary glands, the sympathetic fibers, the postganglionic sympathetic fibers will stimulate the skin. This leads to reddening and sweating of this particular area. So how do you identify it? That test is known as the starch iodine test. So what do you essentially do? You do painting of this area with iodine. Okay, so the auriculotemporal nerve fibers are the ones that supply the the secretomotor functions of the facial nerve. So when the secretomotor functions are going to be there normally, when you do a parotidectomy, these fibers have an aberrant tract that goes to the skin. So when it goes to the skin, after that, whenever the patient is going to have food, normally what happens, there is going to be a stimulation of the salivary gland. So instead of the salivary stimulation, here what will happen is salivary stimulation does not happen. There is a stimulation of your skin. So this leads to erythema and also to sweating. This form of gustatory sweating is what is known as your Frey's syndrome. So how do you avoid that? One thing is you can do, how do you identify this first? You paint the area with iodine. The skin, what you have, you paint it with iodine. Then you let it dry. And after it is dry, then you sprinkle starch powder here. Then you sprinkle starch powder. So once you have sprinkled the starch powder, then you give the patient food. So at the site of food, what happens? The patient's gustatory sweating is stimulated, and because of the sweat, the area will turn blue. So that particular area, the skin where you painted the iodine, this will cause it to turn blue. Why? Because starch reacts with iodine to form a blue color compound. So that is the reason why you get a blue coloration of the skin. So this test is known as the starch iodine test. Now, how can you prevent this Frey syndrome from happening? So at the time of surgery, one is to do the extracapsular dissection surgery. So the extracapsular dissection surgery technique can be done. The other one is in the placement of tissue. You can put flaps like what? One is the sternocleidomastoid, or you can put the temporalis flap, or you can place artificial membranes. So all these have been tried as far as the prevention of this one is concerned. But once it happens, then the effective treatment and the simplest and the most effective treatment is the injection of Botox, which is going to be used for treatment. So postganglionic fibers, they go and innervate the sweat glands of the skin. Sight or smell leads to flushing and sweating. Starch iodine test. Area is painted with iodine and then apply starch after it dries. So this area will turn blue on salivary stimulation. And so these are the areas of prevention. Sternomastoid flap, temporalis flap, all these can be used for prevention. On the other hand, you will have your treatment which will be done essentially. The most important or the most effective technique is going to be by use of your Botox techniques. Okay. Right. So false about Warthin's tumor. It is the second most common benign tumor. Has a high uptake on FDG PET. 10% risk of malignant change and common in smokers, which is the false statement here about. Okay, so all of you got it absolutely spot on. The answer is there is no risk of malignant change. So Warthin's tumor, or what is the other name for Warthin's tumor? Cystadenoma lymphomatosum. So it is a cystic tumor with lymphoid infiltrates, and it's also known as the monomorphic adenoma in some cases. Adenolymphoma is another thing. It is one type of monomorphic lymphoma. There are other types of monomorphic, monomorphic tumors. It's one type of monomorphic adenoma. So the names are cystadenoma, papillary cystadenoma lymphomatosum, adenolymphoma, monomorphic adenoma. These are some of the terms which are used to describe the Warthin's tumor. So it is the second most common benign tumor of the salivary glands. Characteristically, it will have a very high uptake on your FDG PET. The only thing we have to do is, in a patient who has got a FDG PET uptake, rule out a primary. Okay, rule out a secondary. Sorry, you have to rule out a secondary which has gone to the parotid glands. So once you have ruled out the secondary, what is the management for your Warthin's tumor? How do you manage a Warthin's tumor? Large tumors or symptomatic tumors can be managed by excision. Okay, so excision can be by superficial, parotidectomy, or it can be by your extracapsular dissection. Any of these can be done, or adequate parotidectomy can be done. But otherwise, you can observe these tumors also. Small tumors and incidentally discovered tumors can be observed as well. And characteristically, this is also common in smokers. Okay, so pleomorphic adenoma, there is no risk of, in monomorphic adenoma or papillary cystadenoma lymphomatosum, there is no risk of malignant change. It's the second most common benign tumor. High avidity of PET. Why do you have this? Because of the increased levels of mitochondria and the presence of oncocytes within the tumor. That is the reason why it lights up on your PET scan. Okay, so that is the reason why it lights up on the PET scan. And so tumors that are incidentally discovered, not enlarging, not symptomatic, and you do not suspect it is something which is malignancy from elsewhere, such tumors can be observed. There is no need for resection of such tumors. So tumors of the dupe lobe without clinical facial nerve palsy are managed by how? This is the question we discussed, right? So the answer is a total conservative paratidectomy, sparing the facial nerve branches. It is not possible to dissect the deep lobe without first removing the superficial lobe. So facial nerve is completely encased. See again the word here which I have used, completely encased by the tumor. Okay, so if you get the word encased by the tumor, or it is functionally paralyzed. So one, the tumor has to be encased or it is functionally paralyzed. Then you have to go for a radical parotidectomy, including the removal of the facial nerve. Otherwise, you can just kind of remove the tumor alone. So this presents as a bulge in the tonsillar fossa. Now, how do you see this? See, this is how it will present. You can minimally see the bulge in the tonsillar fossa. So this will be the tumor that will be present. You can see that this is a tumor deep to the deeper area in the post-styloid area. You can see the tumor which is there. This is a deep lobe tumor. They may give you a picture. Once this question has come, how will you manage this particular tumor? So this is if the biopsy is pleomorphic adenoma. So low-grade tumors, whenever you have a tumor which is situated only in the superficial lobe, you can do a total conservative parotidectomy. On the other hand, if you have a tumor in the deep lobe, always you will have to go for a total conservative parotidectomy as the management. Right. So malignant salivary gland malignancy, which has got a ETV6 NTRK mutation, fusion mutation, is what? Yes. So the answer here is secretory carcinoma. So that is a characteristic question that came up. This is from Sebastian. So answer is D. Okay, so this is a secretory carcinoma. This is a straightforward MCQ that may come. ETV6 NTRK fusion gene can be seen in your secretory carcinoma. It is also known as the mammary analog secretory carcinoma. So it is something. Risk of malignancy, we already saw that question, what it is. So it is going to be 25, 50, and 75 as far as Sebastian is concerned. But overall, you can remember as 15 to 20%, 50%, and 75 to 90% as far as the salivary glands are going to be concerned. And superficial are managed by superficial or total conservative, as the case may be, depending on whether it's benign or malignant. So when do you do a neck dissection? This is another question that can come. So just like radiation, you have to go for neck dissection whenever you have a T3 tumor, a T4 tumor, when it is a high grade tumor, when there is a node positive tumor. All these are indications for going in for a neck dissection as well. So along with that, for radiation, there is another indication which is adenoid cystic carcinoma, and along with that, perineural invasion and close or positive margins. Whereas only these three, that is T3 tumor, T4 tumor, high grade, and node positive. These are the cases where you will go for a neck dissection as far as the salivary tumors are concerned. Okay, so that ends the session on salivary glands. Let us go on to the next topic, which is going to be your oral cavity tumors. All of you are clear? Yeah, this is the role of prophylactic neck dissection. So T3, T4, high grade, these are all the cases where you will go for a prophylactic neck dissection. Whenever you have node positive disease, that is known as the therapeutic neck dissection. Okay, so then it is not prophylactic, then you call it as a therapeutic neck dissection. 1 second, guys. See here, I put it up. Neck dissection is done as prophylaxis when it is T3, T4, or high grade tumor. When it is node positive, you will go for therapeutic neck dissection. So when you have all these four which are mentioned here are all indications for radiation. Now, along with this for radiation, you will have the presence of PNI, when you have LVSI, when it is margin positive. All these are also going to be indications. And of course, when you have the diagnosis as adenoid cystic carcinoma, all this is also going to be an indication for postoperative adjuvant radiation therapy. Understood, guys? Are you clear? Shall we move on to the next topic? Yes, right. So next is going to be an important topic, which is going to be your oral cavity lesions. We are going to have most of the time the questions in head and neck come from the oral cavity. So let us get on with it. False statement regarding head and neck cancers, epidemiology and causation is close margins generally means when you have a less than 5 millimeter margin, that is considered to be a close margin in head and neck. Okay, when the margin is less than 5 millimeter on pathology, you call it as a close margin on pathological examination. Margins of 5 mm or more, 5 mm or more are considered to be on pathology, are considered to be negative margins. Okay, less than 5 millimeter means it is close margin. Okay, so right. SCC is the most common type of sinonasal carcinoma. HBV associated SCC is associated with apobic changes. Metachronous lesions occur more than 6 months from the primary, and synchronous are more common than metachronous lesions. Aditi has mentioned as D. GM also has mentioned as D. RS, Raman Shankar, okay, Ankit. Okay, so all of you seem to be getting the correct answer. It is D. So what do you mean by synchronous and metachronous? All these are a group of tumors which are known as the second primary tumors. Now, among the second primary tumors, the reason why it happens is something called as the field cancer change. This hypothesis was put up by a guy called as Slaughter. So Slaughter's theory of field cancerization explains the development of second primary tumors. Let us say you got a patient with a carcinoma of the lip. Sometime later, he develops a carcinoma of the buccal mucosa or a carcinoma of the tongue. So that kind of presentation is known as a second primary tumor. So when you are talking about synchronous tumors, that means it is less than 6 months when a tumor appears, that is known as a synchronous tumor. More than 6 months is going to be called as a metachronous tumor. So less than 6 months is synchronous, more than 6 months is going to be metachronous tumor. And we already saw yesterday when we were discussing about the hypopharynx that the most common site associated with the second primary tumors is going to be your hypopharynx. So among all the subsites, when you have a hypopharyngeal tumors, there is a high likelihood that there is going to be a second primary developing elsewhere in the aerodigestive tract. So overall, the incidence is going to be 14% of second primaries in the lifetime of a patient with head and neck cancer. So around 15% is going to be the lifetime incidence, and this is going to be around 0.5 to 1% per year. Roughly, they say the incidence per year is going to be 0.5 to 1% per year, and 50% will happen within the first 2 years. Most malignancies will happen around the first 2 years. So depending on the site, it can be, see, some areas it will be also mentioned as 2 to 7% per year. So the numbers change depending on the book, but overall the incidence is somewhere around 1% per year to somewhere around 5% per year. I don't know the exact number because multiple books mention multiple things, but somewhere around 2 to 3% is the norm. 2 to 3% is going to be the incidence per year, okay, of second primary tumors. And many of these will also lead to death of the patients. Cannot see what you are typing. I'm typing it in the chat box. Can the others see it in the chat box? Oh, sorry. Oh. I guess 1 second. Okay. Fine. I think I was typing it to the host and the pain list, so that is why it's not able to see. So essentially, when you have synchronous tumors, will be less than 6 months. Metachronous is going to be greater than 6 months. Okay, and the incidence is somewhere around 2 to 3 percentage per year. Okay, so 2 to 3 percentage per year. So that is the incidence that you get, roughly speaking. Okay, so that is what I was typing, nothing else. Okay, and this is explained by the Slaughter's field cancerization hypothesis. Okay, it is explained by something called as the Slaughter's field cancerization hypothesis. So what it essentially means, what do you mean by Slaughter's theory of field cancerization? Anybody can explain the Slaughter's theory of field cancerization? Okay, I'll just try to put it simply. See, you have the cause of the cancer, causative agent. So this cause is going to cause a change in the DNA of the entire aerodigestive tract. So what happens is, once you have treated the primary, there are also other areas which already have a few mutations and genetic changes, which is going to lead on to development of a tumor at a different site. And this mucosa which is at risk essentially forms the second primary tumor. Now there is some criteria which is mentioned in Schwartz called as the Warren and Gates criteria, which is important, which I have listed here in the slide. So here you have, so when you look up the Warren and Gates criteria, the pathology should be confirmed at both the sites. Okay, and there should be a separation by normal mucosa of around 1.5 to 2 centimeters. This applies for your synchronous tumor. So when you have a type, let's say you got a tumor in the tongue and then you got a tumor in the lip, that is fine. That is clearly a tumor. But suppose you got a tumor in one area of buccal mucosa and something further behind, then you should have a gap of at least 1.5 to 2 centimeters between the two tumors to be called as a second primary tumor. And again, the pathology should be confirmed in both the areas, and metastasis should be excluded. So metastasis is excluded how? It should happen around 3 to 5 years after the primary. So 3 to 5 years after the primary, if the tumor happens, that is when you will call it as a second primary tumor. If it's suppose you get a tumor in the buccal mucosa, same site you get a tumor again, then it should be at least a period of 3 to 5 years for you to exclude a metastasis. Some authorities go with 3 years, some authorities will take it as up to 5 years. So each one will have a different criteria. Generally, though, 3 years will be what is mentioned as far as the books are concerned. Okay. Right. So apobic, this is one group. Now, as far as the oral cavity cancers are concerned, we have some cancers which are going to be related to your HPV. Now, these metastasis, as in metastasis from the index cancer or recurrence of the index cancer. It is not metastasis, it is a recurrence of the index cancer is excluded. Okay. So what do you mean by recurrence or metastasis from an index cancer is, suppose you have got a tumor in the buccal mucosa, and after 3 to 5 years, if the patient develops a primary, so then you can take it. On the other hand, if it is less than that, then you take it as a recurrence. It cannot be called as a primary. Only then you can take it. When you have two tumors, you will have to stage separately. Each of the two tumors will be staged separately. Each of the two tumors will be staged separately whenever you have two different tumors which are going on. Whenever you have two tumors, you will stage the tumors separately. Clear? Right. So ApoBec, this ApoBec stands for apolipoprotein beta mRNA, apolipoprotein B, not beta, sorry, apolipoprotein B mRNA. So this enzyme catalytic complex, this is found to have a lot of mutations whenever the patient has got a HPV related head and neck cancer. Now, just remember there are multiple things which I mentioned, apobic A, apobic C, so many things are there. Just remember apobic changes can happen as far as the HPV associated head and neck cancers are there. So along with this, you also get an increase in the PIK3CA mutations. These two are very common as far as the HPV related cancers are going to happen. And this is a question that can come. This has come multiple times. So you have got two proteins as far as HPV is concerned. Now E6 proteins stands for early phase protein 6. So E6 protein affects the P53 and E7 protein affects the retinoblastoma gene, and this is how they have their mechanism of action. So E6 and E7, which are secreted by the HPV, these two will affect the P53 and the retinoblastoma gene. One is the guardian of the genome, one is the caretaker. This is known as the guardian of the genome. Retinoblastoma gene, as all of you know, is known as the caretaker of the genome. Okay, so these two are going to be affected whenever you have a HPV related cancer. So P53 and retinoblastoma both are affected. That leads to development of many of the malignancies. So squamous cell carcinoma, all of us know, is the most common malignancy of the oral cavity. But even in the sinonasal tract, we also discussed yesterday when we are talking about PNS tumors. So even in the sinonasal tract, it is still going to be squamous cell carcinoma, which is the most common malignancy which is going to be there. Though the epithelium that you have is a respiratory ciliated columnar epithelium. It's not a squamous epithelium. You will get the ciliated columnar epithelium, which is very prevalent epithelium there. But even though that is the case, squamous cell carcinoma is the most common malignancy in that particular area. Now, in salivary glands, we just now saw that the most common is going to be the excuse me. In salivary glands, we all talked about the mucoepidermoid, which is again a form of adenocarcinoma. So unless you classify it separately, unless the mucoepidermoid component is present, then you will call it as an adenocarcinoma. But all of them are variations of the glandular carcinoma. And then the other subtype, as far as the oral cavity is concerned, is going to be, of course, the lymphoma. The lymphoma is going to be common in your squamous cell cancers. In your tonsils and your oropharynx, you will get your lymphoma, and also in the nasopharynx. All the other areas, these are the common malignancies that will tend to happen. Right. Regarding premalignant lesions, which is the true statement, highest risk is present for erythroplakia. Leukoplakia has a 5% incidence in the general population, and it cannot and is characterized clinically. SMF is related to smoking and to the betel quid. Proliferative verrucous leukoplakia has got a 50% risk of malignancy, and it is not associated with the traditional risk factors. So, which is the true statement here? Okay, Vijay, Harsh, Makarant has put as A, Ankit, all the rest have put as D. Mohak Mankat has put it as D. Realme is saying it is C. Okay, so most of you got the answer right. It is D. So proliferative verrucous leukoplakia has got a 50% risk of malignant transformation, and it is not associated with the traditional risk factors. Okay, so now what is leukoplakia or what is erythroplakia? These are lesions which are characterized as white or red patch or plaque that cannot be characterized clinically or pathologically as any other entity. So what it essentially means is when you have any lesion in the oral cavity or in the entire oropharynx where you have a white patch or a red patch, it cannot be rubbed off. First thing is it should not be a food particle or a residue or something like that. So it cannot be rubbed off. Okay. So the first thing that you have to remember is it cannot be rubbed off. And it cannot be characterized clinically or pathologically as any other entity. Suppose you do a pathology of the lesion and some other lesion comes up in that, then you cannot call it as a leukoplakia, then it will be labeled accordingly. But if you cannot get a diagnosis either clinically or pathologically on this, and it is a white or a red patch or plaque, so that is what you will call it as. That is what you will call it as a leukoplakia or erythroplakia. Okay, so leuko or erythroplakia is going to be defined by this. Okay, So now, which premalignant lesion has got the highest risk of malignancy? I have put here highest risk of malignancy is with erythroplakia. So if it is not erythroplakia, then which has got the highest risk of malignancy? Yes, so it is the speckled leukoplakia or speckled erythroplakia. Both of them mean the same. Speckled erythroplakia or speckled leukoplakia, both of them mean the same. So that has got the highest risk of malignancy. Let there be no doubt among this. So the answer will be, when you have risk of malignancy, it will be speckled leuko or erythroplakia, which will have the highest risk. And then you will have possibly erythroplakia, or it can be proliferative verrucous leukoplakia as well. Either of these two is going to be the second type, and then least is going to be your leukoplakia. So that is the order in which it will come. Okay, right. So speckled leukoplakia has got the highest risk of malignancy in the oral cavity. So as I already said, speckled, then you have erythroplakia, and then you have leukoplakia. Leukoplakia has got a 2% incidence. It's not a 5% incidence, about 2% in the general population. SMF. Now, SMF, that statement, did any of you look at it? It is related to smoking and betel quid. It is mentioned here. So smoking has got no relation as far as your submucous fibrosis is concerned. It is only related to the betel quid, the pan or the betel quid chewing. It is particularly common in the Southeast Asian population, Southeast Asian and Indian population. That is where you will commonly get your SMF or your submucous fibrosis. It is not related to smoking. So reverse smoking is the one which is common for causing your hard palate cancers. It is also called as the chutta cancer. There is a particular kind of BD or something which will be placed inside. The smoking tip will be placed on the inner aspect, and then they will place it. So sometimes there is a chronic damage which can happen because of that. That leads to hard palate malignancies. Now, what is dyskeratosis? What is parakeratosis? These are some terms that may come as MCQs. Dyskeratosis is abnormal keratinization of the epithelial layers. So what do you mean by dyskeratosis is essentially in the epithelial layers, you will not get keratin. When keratinization happens, that is known as dyskeratosis. And parakeratosis is the presence of nuclei. Okay. So this abnormal keratinization is known as dyskeratosis, and the presence of nuclei is going to be known as your parakeratosis. Both of these may come as direct MCQs. Right. Now going on to incorrect staging, which is the match. We yesterday discussed this staging tumor. Okay, so now tell me which is the incorrect match here. So single mobile ipsilateral node 3 cm without extra capsular extension is N2A in HPV negative. Multiple mobile ipsilateral nodes, all 3 centimeters without extra capsular extension is N2A in HPV positive. Single mobile contralateral 6 centimeter node without extra capsular extension is N2 in HPV positive. Single mobile ipsilateral 3 centimeter node with overt extra capsular extension is going to be N3B with HPV negative. So which is the incorrect statement here? So actually, my friends, this one has got multiple incorrect statements. I think the answer should have been, okay, let's look at it. Single mobile ipsilateral node 3 centimeter without ECS. What is the grouping for this? What is the grouping? Is A true or false? Yes, so this one is N1. So this is a false statement. This is incorrect. Okay. Multiple mobile ipsilateral nodes 3 centimeters without extracapsular extension, N2A in HPV positive. What about this one? Is this true or false? B. Yes, because it is ipsilateral nodes. The only thing that you look for is whether it is ipsilateral or contralateral. So this is a true statement. And again, but the only thing is it does not have N2ABC. So that is why this is also a false statement. So if this A has not been there, then it will be a true statement. So this is again a false statement. Single mobile contralateral node 6 centimeter without ECS in HPV positive is N2. What about this one? Yes, this is true. Remember, my friends, the node has to be more than 6 centimeters to be called as N3. Okay, so this is still an N2 node only. More than 6 only will come under N3. So in your HPV positive individual, single mobile node, whether it's ipsilateral or contralateral, whatever, I mean, if it is any node which is going to be less than 6 centimeter, that will be coming under your N2 node. Okay, so less than 6 centimeter and contralateral, then or less than or equal to 6 centimeters and contralateral, that is going to come under your N2 node. Less than or equal to 6 centimeter and ipsilateral is going to come under your N1 node. So this is a true statement. So the first one is false. The second one is false. This one is a true statement. What about this one? Single mobile ipsilateral node, 3 centimeters with overt extracapsular extension is N3B. What about this one? No, not 3C, that is 3B only. So this is also a true statement. No, this is a true statement. So you got the first two which are false and the second two which are true. I think I made some mistake in the typing. Okay, so I should have not put N2A, it should have been N2 here. So that is why that mistake has come. Okay, so the incorrect statement here is actually only A. All the rest are going to be positive. This should have been N2. Okay, so if you look at this statement, kindly correct it in your notes. Okay, so this one is first is false. See, HPV correlation you want. Okay, so as far as HPV positive is concerned, when you take up N1 is less than or equal to 6 centimeter ipsilateral, N2 is less than or equal to 6 centimeter contra or bilateral, and N3 is more than 6 centimeter. That's all. This is as far as HPV positive is concerned, and the same thing applies for nasopharynx as well. Along with that, in nasopharynx, you will have an additional thing. N3 is ordered to distal border of cricoid. So whenever you have a node which is extending beyond the distal border of the cricoid cartilage, that will also become N3 node. Okay, so nasopharynx is the same as HPV positive. One additional factor will be any tumor, any node which is going to be ordered to the distal border of the cricoid cartilage. So that is going to be your N3. Now you understand for HPV positive and for nasopharynx. Anyone has a doubt with regard to that? Clear, everybody? Right. Now let us talk about rest of the. See, just go through this again. If you look at the chat box, whenever you have HPV positive, what happens? You have N1 which is going to be less than or equal to 6 centimeters and ipsilateral. When it is N2, it is again less than or equal to 6 centimeters, and it can be either ipsilateral or it can be either contralateral or it can be bilateral. Any node more than 6 centimeters straight away goes into N3. Okay, this is only there for HPV positive. The same staging will apply for nasopharynx also. In addition, yes, HPV positive will not have N2ABC or N3AB. It will only have N1, N2, and N3. Same thing applies for your nasopharynx as well. So nasopharynx, if you want to talk about the staging, N1 is less than or equal to 6 centimeter ipsilateral. N2 is less than or equal to 6 centimeter contralateral or bilateral. N3 is any node greater than 6 centimeter or distal to over cricoid. Okay, so this is going to be the classification for nasopharynx and for your HPV positive oropharynx. Are you clear now? Anybody has a doubt with regard to this? Yeah, HPV negative, I will talk now. So when you talk about HPV negative, or generally speaking for all the head and neck, otherwise, the rest of the head and neck, the same classification will apply. N1 is, so what are the things that you will consider is whether it is single or multiple, whether it is, ipsilateral or bilateral, and then you will take the size. So single ipsilateral less than or equal to 3 centimeters. This is going to be N1. Okay, this is the easiest one to remember. Single ipsilateral less than or equal to 3 centimeters. Then you have N3. I will directly go to N3 first. So N3A is there, which is any node more than 6 centimeter. Then you have your N3B, which is the highest staging where clinically overt extracapsular spread. So how will you know this extracapsular spread? Either fixity or matted nodes. So this should be clinically overt. So irrespective of the size, any node, suppose you have a 2 centimeter node, which is clinically extracapsular spread, or they have mentioned the word matted, or it is fixed if they have mentioned, then it straight away goes into N3B. Have you gotten N1 and N3A and B now? Is that clear now? Yes. Clinically overt. It's not microscopic. It can have a pathological ECS. That is why I mentioned the word clinical in capital. So pathological ECS is not a criteria. Okay, pathological ECS is not a criteria for clinically grouping it. Okay, pathologically you can have extracapsular spread, but you are looking at clinical. Suppose you find a node, the node is only 2 centimeters, but it is stuck to the mandible, stuck to the surrounding area structures, or stuck to the nodes itself, causing a matting of the nodes. Then you call it as a N3B node, irrespective of the size. So essentially, you should have matted node, or it should be a fixed node. So when you have a matted or a fixed node, that is going to be an N3B node, irrespective of the size. Okay, and N3A is only the size more than 6 centimeters. Clear about N1 and N3A and B? Anybody has a doubt in N1 and N3A and B? All of you are clear? Right. Now let us go to N2. N2, the easiest one to remember is N2C. It has to be contralateral or bilateral. So whenever you have a node which is contralateral or bilateral, that has to be an N2C node. Okay. Then when you have multiple nodes, but they should all be less than 6 centimeter and all be ipsilateral. Okay. Now do you get it? So N2B is ipsilateral, multiple, and they should be less than 6 centimeter. Clear? What remains now? So it cannot be multiple, so it has to be single. What is the only thing that remains? It has to be single. Can it be contralateral? No. If it is a contralateral node, it will go to N2C. Can it be more than 6 centimeter? No. It will go to N3A. So it has to be single. It has to be mobile. It has to be ipsilateral, and size should be more than 3 and less than or equal to 6 centimeters, and this will be your N2A. Now do you understand? All of you, did you understand now? So N1 is single, ipsilateral, less than or equal to 3 centimeters. Okay. N3A is more than 6 centimeters, and 3B is going to be ECS, clinical. Remember, again I'm stressing, it's a clinical ECS. So any node, irrespective of size, if it is got a clinical extracapsular extension, it is N3B. And same way, when the size becomes more than 6 centimeters, it goes into N3A. So then you have your N2. In this, N2C is going to be your contralateral or your bilateral. N2B is what? It is going to be multiple. Whenever you hear multiple, and obviously it has to be ipsilateral, because if it goes to contralateral nodes, then it will become a N2C. So multiple ipsilateral. Again, one more thing should be there. It should be less than 6 centimeters, less than or equal to 6 centimeters. Now do you understand? Now do you understand? Everybody is clear? So what is left? Only N2A will be there. So N2A is going to be single, ipsilateral, and the size should be greater than 3 and less than or equal to 6 centimeters. So this is all is there as far as the staging is concerned. Understand it, then you will find it easy. Go back from below to above. Yes, everything else is ECS negative. Whenever a node is ECS positive, clinically overt ECS, straight away it goes into N3B. N3B is the only one which will have ECS positive. So whenever a node is ECS positive, it straight away goes into N3B. Only N3B will be ECS positive. Okay, right. So that is why you got now. Let's look at this chart now. So single mobile ipsilateral node 3 centimeter without ECS. What is the stage for this? What is the stage for A? N1, correct. So multiple mobile ipsilateral nodes, all 3 centimeters without ECS. What is the stage? What is the stage for B? Yes. So whenever you get multiple, it has to be directly going into N2B. Don't just write N2. It is going to be N2B. Okay. But here N2 Mohawk, what he has typed is right, because what you have to clarify here, it is a HPV positive tumor. So the things that you will have to look for, it is not N2B, it is only N2. Suppose this were HPV negative, only then it will be N2B. Okay. Otherwise, it has to be N2 only. Okay. What you have written Mohawk is right, because this is a HPV positive tumor. So HPV positive tumor, this one is not even, this is not even N2. This is going to be an N1 tumor. Do you understand? This is not N2A, this is not N2B as far as HPV positive is concerned. This is a N1 tumor. Do you understand? Because all of the nodes are ipsilateral and they are less than 6 centimeters. So ipsilateral less than 6 centimeters is directly going to go only into N1 as far as the HPV positive is concerned. N2 is what? It is going to be contralateral or bilateral, and again less than or equal to 6 centimeters. Okay, so look at whether, first thing you look at is whether it's HPV positive or negative. Now let us assume all of this is HPV negative. So when you go by that definition, then single mobile ipsilateral A is going to be N1. Okay, in your HPV negative, if you take it, A is going to be N1. B, multiple mobile ipsilateral nodes, all 3 centimeters without ECS. So this will come under N2B. Okay, so single mobile contralateral node 6 centimeter without ECS. This will go under N2C. Okay, and D, multiple ipsilateral node with clinically overt ECS, that will come under N3B. Are you able to understand now? Everybody is clear? So first look at whether it is HPV status. Okay, so first look at the HPV status, then look whether it is nasopharynx. If it is HPV positive or nasopharynx, then it goes into a different staging. For all other head and neck, it is going to go into a different staging. So all other head and neck, as I said, ECS, clinical. Look at whether ECS is there. If it is there, straight away it goes to N3B. Then you look at the size. Size is less than or more than 6. More than 6, it is N3A. If it is not these two, then you look at N1. So N1 is what? Single ipsilateral less than or equal to 3 centimeters. So that is going to be N1. On the other hand, you have contralateral or bilateral. Contralateral or bilateral. When you have that, that is going to go into N2C. Multiple, and it is going to be ipsilateral. And again, size is less than this one, so then it will go to N2B. Are you clear now? All of you have got it clear now? Any doubts with regard to this? Some question will usually come from this. That is why I'm stressing and spending so much time here. All of you clear on this? Right. Okay. So now let us go on to the next question here. Okay. So HPV positive nodes, multiple nodes, ipsilateral will be, it is not N2, it is actually N1. Sorry, I marked it wrongly here. Kindly correct it. So multiple nodes or single node, whatever it is, if it is an ipsilateral node, it is going to be N1. Kindly change it. It is going to be an N1 node. And in HPV, there is going to be no N2, A, B, C and all. Okay, there is going to be only an N2. Okay, so ipsilateral less than 6 is going to be N1. Contralateral less than 6 is going to be N2. And when you have a node which is more than 6, that is going to be N3. Okay, so kindly correct this. This is a error that I have typed it here. This is N1. This is not N2. Okay, so in HPV positive, this is what I said. Okay, right. So this is again the same staging. We already had a discussion on this yesterday. It is there in your notes as well. So you can look up the notes as well. So that will tell you whatever is there very clearly. So the only point with regard to EBV positive is for nasopharynx. So whenever you have that, that is the caudal border of the cricoid cartilage. That is the extra point that will come. Otherwise, it is all going to be the same. One more thing, retropharyngeal. So retropharyngeal will come under N1 nodes in your nasopharynx. Okay, when you have your nasopharynx tumors, retropharyngeal nodes will come under your RP nodes, whether it's unilateral or bilateral, it will come under your N1 nodes. Okay. So in nasopharynx, unilateral or bilateral, as long as it is less than 6 centimeter, this is going to come under your retropharyngeal nodes, will come under your N1 tumors. Okay. Right. So next, going on to the T staging. Now that we have talked about the N staging, let us talk about the T staging. This is again very similar that you have to remember. So what is T1? All of us know this, less than 2, less than or equal to 2. Again, let me be clear. Don't forget that equal to, less than or equal to 2. Then you have your T2, which is going to be more than 2 and less than or equal to 4. Then you have your T3, which is more than 4 centimeters. And T4 is going to be ABC, which is all going to be local invasion. Now, there is an additional factor which is included, which is known as the depth of infiltration. So, the depth of infiltration or the depth of invasion, you classify it as less than or equal to 5 millimeter. Now, when the tumor is less than or equal to 5 and less than or equal to 2 centimeters, that is a T1 tumor. Okay. So, when you have a tumor which is either more than 2 centimeter, that is straight away go into T2. Okay, we already saw that. More than 2, less than or equal to 4. That is going to go into T2. Plus, in addition, when you have a tumor which is less than or equal to 2 centimeter, but the depth of infiltration is greater than 5, less than or equal to 10 millimeter. This will also come under T2. This will also come under T2. We will have two things as far as the T2 is concerned. So you look at it here. Look at it here. Less than 2 centimeters. Depth of infiltration is less than 5 millimeter. Less than 2 centimeters and depth is between 5 and more than 5 but less than 10. And again 2 to 4 centimeters with the depth of infiltration overall is less than 10. Okay. Then what is T3? Any tumor which is more than 4 or more than 10. Whenever you have that, that will go under T3. Can you remember this? This is an easy way to remember. Okay. So in a sense, you remember for T1 and T2. T1 is less than or equal to 2, less than or equal to 5 mm DOI. Okay. T3 is what? Greater than 4 centimeters or greater than 10 millimeter DOI. All the rest will come under T2. Simpler to remember? Can you remember like this? So whenever a tumor is given, look for these features. What is the size? What is the depth of infiltration? Size, whether it is less than 2 and the depth is also less than 5, then it will come under T1. Size is more than 4 or the depth is more than 10, straight away it will go under T3. If it is intermediate between the two, then it will come under T2 tumors. All the rest will come under T2. Do you understand? Of course, whenever we have infiltration, invades the cortical bone, inferior alveolar nerve, floor of the mouth, skin of the face, and again maxilla or mandible is involved or involves the antrum, involves the skin. All this is going to be considered as T4A. This most of you will be very aware. So what are the structures which are going to be here nearby? So nearest structure is going to be the mandible or the maxilla. So bony involvement is going to make it as a T4A lesion. Then it involves the skin of the face. So that is also going to become a invasion of the T4A lesion. So these are all things which can be easily resected. That is why it is known as a T4A lesion. The same thing applies for a T4A of the lip, involving of the the skin of the face or the floor of the mouth. From here it goes on to the floor of the mouth or in this area where the inferior alveolar nerve is going to come out as the mental nerve. So that also, when it is involved, that will cause it as a T4A of the lip. All of you are clear with regard to the T staging? Anybody has a doubt with regard to the T staging? Okay, so everyone is clear. So what is this locally advanced disease? Very locally advanced disease whenever you have. So that you have as tumor invades the masticator space, pterygoid plates or the skull base or internal carotid artery. Don't forget this. It is the internal carotid artery if it is in case, because external carotid artery still you can resect it without any problem, or you can tie it off as well. So involvement of the internal carotid artery, pterygoid plates, when it involves the pterygoid plates, or it involves the masticator space, or it involves the skull base. So these four, whenever it is there, that is known as a T4B or a very locally advanced disease. So what do you mean by this very locally advanced disease is, essentially when you have a very locally advanced disease, surgery is not possible. Surgery cannot be done when the patient has got a T4B disease. Okay, T4B disease, straight away surgery planning is going to be difficult. So till T4A, surgery will be the treatment of choice as far as the management is going to be concerned. Till T4A, in a patient, you can plan for resection. When it is T4B, you cannot plan for surgery. Right. So this is the stage grouping. I've just put it up here. You need not memorize this stage grouping. Generally, it will not be asked. Right. Regarding investigation, so when you made the diagnosis, external carotid artery will be T4A, correct. So anything else which is going to be there is going to be T4A, right. So mandibular invasion is assessed preferably with an X-ray oral pan tomogram. CT with contrast is the preferred investigation for oral cavity SCC with the dental amalgam. PET CT is indicated in patients with T4 lesions or with lower neck nodes. MRI is the preferred modality to assess for invasion of the bone marrow, which is the false statement here. Okay, Harsha said A, Bharadwaj says A, Vijay A, Ankit says B, Aditi says A, Redmi says B, Raman says A, Dr. Bashir says D. Okay, so many of you are finding it, most of you have gotten it right. A is the correct answer. So what is the best method to assess your mandibular invasion? So whenever you have a patient, let's take it one step at a time. Okay, so whenever CT is going to be used, see CT and MRI, which is the best investigation. So this is a commonly asked question in the examination. So MRI is generally, if they ask you without any qualification for your oral cavity, then you mark it as MRI. Specific scenarios are there where you use a contrast enhanced CT. One is the cortex or cartilage invasion. Okay, so whenever you have a cortex invasion or a cartilage invasion, then you have to look for contrast CT. On the other hand, marrow invasion, bone marrow invasion is going to be preferably done by an MRI. So what is the role of OPG? It is only used for dental assessment. It is no longer going to be used for your bony invasion. Bony invasion is going to be essentially assessed by a CT scan. The problem with the CT scan will be the presence of amalgam, which will show up artifacts. Okay, so whenever the artifacts are going to be there due to the amalgam, so here you will prefer to do an MRI. So whenever you get the answer as oral cavity, okay, if they mention just as oral cavity without any qualification, the marked answer should be an MRI. If they ask you for cortex or for cartilage, for lymph nodes in head and neck, which is superior, neither CT nor MRI is actually very good. There is no real difference between the two as far as the lymph nodes are going to be concerned. None of the investigations is actually good enough. We have to, that is why always in the head and neck area, we always go for a elective neck dissection, because we cannot find out by any imaging modality. That's why we do an elective neck dissection. Elective neck dissection is always done in patients with head and neck, just because of this reason, because we cannot assess the nodes. Of the two, probably I will choose CT as the option, but that is a query. I'm not sure whether CT will be the preferred answer in an examinations. But in general, for oral cavity alone, if they mention, then you mark it as MRI, which will be the preferred thing. If they ask you again for amalgam, again MRI is the choice. If they ask you for the bony cortex invasion, or they say you want to assess a cartilage invasion, then you go for CECT as the option. Okay. On the other hand, when you have marrow invasion or soft tissue, if they have used the words, then the option is again going to be an MRI. So these are some clues that you will look for as far as the exam is concerned. Okay. So MRI is going to be used for the soft tissue invasion, perineural invasion, parotids, bone marrow invasion, parapharyngeal space, all this MRA is going to be preferred, and also in the presence of dental amalgam. CT is going to be for cortex and also for the cartilage. You can remember C for C. Cartilage and bony cortex is going to be by the CT scan. Marrow is going to be MRA. So M for M, C for C, and M for M. Okay. Bony cortex is going to be by the CT, and bony marrow is going to be by the MRA. Now, PET CT, when do you do? It has even come in the NCCN guidelines when you have large primaries like T3, T4, lower neck nodes are there, then to rule out the lung metastasis, you will prefer to go for a PET CT for evaluation of the patients. Okay. So these are some of the investigations that you will do in the evaluation of oral cavity lesions. Right. So whenever you have a lesion, you will have to plan for a biopsy. Now this biopsy can be done as an office procedure. In some cases, you may also need to do whenever, especially there is a large painful lesion, then you may need to go for an examination under anesthesia with an incision, or it may be called as a wedge biopsy. So incision or the wedge biopsy is the preferred biopsy as far as the oral cavity lesions are going to be concerned. Incision or a wedge biopsy with a bit of normal tissue. So dental assessment will be done with the X-ray oral pantomogram, and MRI with gadolinium is preferred for oral cavity lesions for the soft tissue examination. So some other uses where you consider going for an FDG PET. It is used already, as I mentioned, in T3 or T4 disease, lower neck nodes, when you have got multiple neck nodes which are there. Plus, other than that, when you are going for unknown primary with neck nodes, PET CT is always indicated. The same way, when you are going for a non-surgical management of oropharynx or any other area where it's going to be a non-surgical management by CTRT, then a PET CT is always indicated. Why do we need a PET CT in this scenario? Why do we need a PET CT in this scenario? Yes, so to assess the response, not the PCR, but yes, for response assessment. So the metabolic activity, the metabolic response, also we call it as the metabolic response assessment. So that is what the metabolic activity will be assessed. So metabolic activity can be assessed, and if there is a reduction in the metabolic activity, so that will be assessed by your PET CT, and that will give a clue to the responsiveness of the tumor. So when you are doing an ultrasound, what is the role of an ultrasound? It is used for basic screening of neck swellings alone. So whenever you are having a neck swelling alone, it can be used for basic screening one, and the other one is for a guided FNAC or a guided biopsy of the node. You can do it under ultrasound screening. Bone scan, again, there is not much of a role in today's world as far as bone scan is going to be concerned. So when will you do a triple scopy? So this triple scopy, what do you mean by triple scopy? You will do a bronchoscopy, esophagoscopy, and a direct laryngo and a pharyngoscopy. This is known as your triple scopy. Now, in today's world, where you're going to do a PET CT or a CT scan, the role of triple scopies has come down. The reason why we are avoiding this is because previously there used to be a lot of synchronous cancers. Now, these can be picked up by doing the CT scan or by doing the MRI of the entire head and neck area, or when you're doing a PET CT, the entire area is going to be covered. So, because of this, endoscopy is no longer a routine. So, endoscopy is no longer considered to be a routine. But if at all the triple scopy needs to be done, then we have to go for a bronchoscopy. At the time of bronchoscopy, you'll also examine the nasopharynx, and then you will go to the throat, where you will be doing the direct laryngoscopy and the pharyngoscopy, and then you will also go for a bronchoscopy as well. Then you will go for a esophagoscopy. All these are important. The entire aerodigestive tract will be at risk, and that is the reason why you do this triple scopy. Right. So regarding neck dissection, elective neck dissection is indicated for all squamous cell carcinomas, depth of infiltration more than 4 millimeter. It is indicated when the risk of metastasis is more than 20%. The most important morbidity is shoulder dysfunction as far as R&D is concerned, and skip metastasis to level 4 occur in carcinoma of the tongue, which is the false statement here. Ankit has messaged as 8. Mohak also says A. Habiba says A. Yes. So what is the correct answer? Why is A wrong? Yes. So it is anything with the depth of infiltration more than 3 millimeter, not more than 10 millimeter, where there is a depth of infiltration more than 3 millimeter, not 5, not 10. So any depth of infiltration more than 3 millimeters, you should plan for elective neck dissection. What do you mean by elective neck dissection? Elective means prophylactic neck dissection. Elective or prophylactic neck dissection. So it should be greater than or equal to 4 millimeter, or it should be greater than 3 millimeter. Be very clear. Both of these are the same. Greater than or equal to 4 millimeter. Greater than 3 means it is 4. So 4 and above. That is the criteria. So when the depth of infiltration is greater than 4 millimeter, you have to go for something called as an elective or a prophylactic neck dissection. So what is a therapeutic neck dissection? That will be done in node positive disease. Whenever you have a node positive disease, you will go for a therapeutic neck dissection. Otherwise, you will go for an elective neck dissection. So elective neck dissection is done when the DOI is more than 3 millimeter, when the depth of infiltration is going to be more than 3 millimeter, or when the risk of neck node metastasis is more than 20%. All these cases, you will go for a neck dissection. Practically speaking, you will require a neck dissection for almost all oral cavity lesions. There is only one exception. Where will you not do a neck dissection? Which case a neck dissection is not done? No, not CIS. Yes, lip primaries. Why in lip primaries you will not do? So less than 5% node metastasis. Okay, so less than 5% node metastasis. So in your lip, you will not go for an elective neck dissection. All other cases, you will go for an elective neck dissection. Okay, so in your lip cancers, you will not go for an elective neck dissection. All other cases, you will have to plan for an elective neck dissection. Right. So some of the other factors on pathology. Let us look at this now. So elective neck dissection is indicated for all cases where the depth is more than 3, and this is an important point for measurement of depth. So where do you measure it? It is from the adjacent normal basement membrane, the normal basement membrane. So you have to take the normal tissue, the edge of the tumor should be taken. Okay, there you take the basement membrane, and that is one line which is drawn. You can see the blue line which is drawn there. And then you take the deepest extent of the tumor. Okay, so you take the deepest extent of the tumor. So this you can see here, this is still this area, the tumor is extending, and then you make the measurement. The vertical line is drawn from here to here. This depth is measured as 6 millimeter. So when you have an ulcerated tumor, what happens? The tumor thickness is not equal to the tumor depth. This is the main factor that we need to remember. Thickness, there are some people who will think that thickness is equal to DOI. That is wrong. Okay, thickness is not equal to DOI. DOI is going to be measured from the nearest basement membrane. Okay, from normal basement membrane to deepest tumor. So what happens as far as the depth of infiltration is concerned when you have a tumor which is going to have this one? So in ulcerated tumors, the thickness will be less than the depth of infiltration. So people will think you have measured a tumor as, let us say, 4 into 3 into let's say about 0.5 centimeter. This is the measurement of the tumor, but the depth of infiltration will be mentioned as 8 millimeter. So how is this possible? This is possible because already there is a ulceration. Can you understand here? Going by the picture, in an exophytic tumor, on the other hand, you can see that this is there. So again, here the tumor thickness is going to be less. Can you understand? See here, the tumor thickness is going to be from here to here only. This is the tumor thickness, not this. Sorry, this is going to be the depth of infiltration. Okay, and this is going to be the tumor thickness. So in your exophytic tumors, the thickness will be, so in exophytic tumors, the thickness is greater than the DOI. Excuse me. So in your ulcerated tumors, thickness is less than the depth of infiltration. Do you understand this now? Anybody who has a doubt with regard to this concept? The diagram is very self-explanatory, but still I'm just explaining it a little bit. Can you understand what is the difference between thickness and depth of infiltration now? All of you got it? Shall I proceed? Right. So this is how you measure the depth of infiltration and the thickness. So anybody where there is a depth of infiltration of more than 3 millimeter or the risk of spread is going to be more than 20%, then you will have to go for an elective neck dissection. So neck dissection is gradually divided into majorly into two types. One is the comprehensive type and the other one is your selective. Compared to most people, what you will think as radical and modified radical, no, it is comprehensive and selective. So what do you mean by comprehensive? Comprehensive is 1 to 5 levels. All these levels are removed whenever you're doing a comprehensive neck dissection. When you're doing selective, any one of the levels will be left behind. That is known as your selective neck dissection. And again, as I already mentioned here, in your selective neck dissection, at least 10 notes need to be taken. This is according to the AJCC criteria. And when you do an MRND or an RND, at least 15 notes have to be sampled. Do you get that? So 15 nodes as far as an MRND or a radical neck dissection is concerned, and selective neck dissection, you have to sample at least 10 nodes. So when you take up the carcinoma of the tongue, this is a different tumor because you get something called as skip metastasis. Now normally, as far as the oral cavity is concerned, the metastasis happen in level 1 to 3. Now tongue can have skip lesions. So skipping 1 and 2, it will directly go to 3 or 4. So that is why whenever you are doing a tongue neck dissection, number of nodes, I have put it here, you can see it here. You can see it here, Pradeep, it is there in the notes. Selective neck dissection is 10 nodes, MRND or RND is going to be 15 nodes. Okay, so in your tongue, when you're talking about an elective neck dissection, you will always do something called as an extended SOHND, extended supraomohyoid neck dissection, which means it is level 1 to 4, which will be removed. For your oral cavity, you will do a SOHND, which is going to be level 1 to 3. Okay, so tongue it will be 1 to 4, oral cavity it will be 1 to 3. This is a extended supraomohyoid neck dissection. For oral cavity, you will do only supraomohyoid, which is going to be level 1 to 3. But in your tongue, carcinoma tongue, because of the skip metastasis to level 4, you will always do an extended supraomohyoid neck dissection from level 1 to level 4. Got it, everybody? All of you are clear? Right. So these are the neck node stations that we have. This is an important thing that keeps coming repeatedly in our examinations. All of you will be aware of this, but still I'm going to repeat it here. Now, how do you classify the level node stations? So 1A and 1B is going to be the submental and the submandibular node. Okay. So 1A is no laterality. Very clearly, remember, 1A is the submental triangle. It does not have any laterality. As you can see here, it is the anterior belly of digastric on both the sides, and then the hyoid bone. That is going to be your 1A. In the diagram, you can clearly see anterior belly of digastric on both the sides and the hyoid bone. Whereas all the other structures are going to be bilateral. Your level 6 is bilateral. You have got a left side at level 6 and a right side in level 6. The same way, level 7 will also be, depending on this side or this side, it will also be bilateral. Okay, so your level 6 and 7 are going to be bilateral. Only level 1A does not have any laterality. So 1A is going to be anterior belly of digastric on both the sides, and inferiorly is going to be bounded by your hyoid bone. So that is going to be your 1A level. 1B, it is also known as the submental triangle. So submental triangle, anterior digastric or hyoid, and it is known as your 1A, right? So what is 1B? So you have both the anterior or posterior digastric. The other side you have the mandible lower border, and this is known as the submandibular. It is known as the submandibular triangle. So you can see it here: anterior belly of digastric, posterior belly of digastric. You got the lower border of the mandible. So this is known as the submandibular triangle. Okay, so this is known as the submandibular triangle. All the rest are going to be the lateral group of lymph nodes. So in the lateral group, you got the anterior and the posterior. So let's talk about the posterior first. You can see this line here. So what does this line denote? This is what is the difference between the anterior and the posterior? The differentiation border is the posterior border of sternocleidomastoid. So the triangles anterior and posterior are divided by the posterior border of the sternocleidomastoid. I have drawn it clearly here. See, so whatever is posterior is going to be the posterior border of the sternocleidomastoid. Then you divide the neck levels. So here what you can see, this is the mastoid neck level. The mastoid process, you can see it here. What you can see here, this level is the level of the hyoid bone. This is the hyoid bone. So one level is the mastoid. So then you have the hyoid bone, which forms the next level. What is the third level? You can see, you cannot see it here, but the third level will be at the level of the cricoid. So cricoid will form the third level. So you have the mandible, sorry, you have the mastoid process, which forms the superior level. Then you have the level of hyoid, you have the level of cricoid, and then of course you have the clavicle here. These are the four boundaries that will divide your neck node stations. The lateral neck nodes are divided as, that is, mastoid to hyoid is going to be level 2. Okay, so mastoid to hyoid is going to be level 2. Hyoid to lower cricoid is going to be level 3. Cricoid to clavicle is going to be your 4. Okay, and again for all of this, the posterior border is going to be the posterior border of your sternomastoid. So what does it mean? All nodes deep to SCM are the anterior nodes. All nodes which are deep to SCM are all going to be your anterior nodes. So you can see here, this is the muscle, this is the anterior border, this is the posterior border. So all the nodes will be coming under level 2, 3, 4 only. They will not go to level 5. Are you clear with regard to this? So now you have the level 2A and 2B, which is going to be divided by the this particular thing, which is the sternomastoid nerve. Which is going to be by the 11th cranial nerve. The 11th cranial nerve or the spinal accessory nerve, whatever is antro inferior is 2A, posterior superior is going to be 2B. Okay, and 5A and 5B, how do you divide? It is at the level of the cricoid. So cricoid will divide it as 5A and 5B. All of you are clear now with regard to the neck node stations? Anybody has a doubt with regard to the neck node stations? Is that clear for all of you? All of you got it? Yes. So if you take up, then why do you call it as the SOHND or the supraomohyoid? So supraomohyoid is because the omohyoid muscle crossing or the tendon or whatever you call it, the anterior belly or the superior belly or whatever you call it, it's the superior belly, not the anterior belly. The tendon and the superior belly is going to be there at the level where you can see. So you can see here, this is going to be the level where at the lower border of cricoid, no? So this is going to be the level where you are going to have the omohyoid crossing. So that is why your level 3 and 4 is known as your supraomohyoid. This level, omohyoid, will separate your omohyoid will essentially form the boundary between level 3 and 4 as far as the soft tissues are concerned. Soft tissue boundary will be the omohyoid. Did you get it? Omohyoid, the soft tissue boundary is going to be between level 3 and 4 is going to be formed by the omohyoid. That is why you call it as a supraomohyoid neck dissection. You look at this, the omohyoid till here is there. So above the omohyoid, whatever you are going to dissect, what is there? It is going to be 1B, 1A, 2A, 2B, and your 3. Above this level, you are dissecting. That is why it is known as the supraomohyoid neck dissection. Okay, so SOHND is going to be all these 1A/B, 2A/B. Then you have your level 3. That is going to be SOHND. Along with this, you have the submandibular gland as well. The submandibular gland is always resected whenever a 1B dissection is done. You will always resect the submandibular gland. It is always a part of your neck dissection because it is included in your 1B and it will have a few nodes which are attached to it. Are you all clear? Is everyone clear? Any doubts with regard to this? Right. So if you take up the oral cavity, level 1 to 3 is going to be done. That is known as the supraomohyoid neck dissection. Tongue will have skip metastasis to level 4. So that is why you will do an extended supraomohyoid, or you will do from level 1 to 4 completely. So level 6 and 7 you will do, which is essentially done for central neck dissection. What we call as the central compartment dissection will be done for your subglottic tumors, for thyroid, for hypopharynx, and for the cervical esophagus. Now, whenever you have a larynx or hypopharynx tumor, then you will go for a level 2, 3, 4 neck dissection. Okay, so whenever you have a larynx or a pharynx tumor, you will go for a level 2, 3, 4 neck dissection. Okay, so larynx or pharynx, you will go for 2 bar, 3 bar, 4, and that is known as your lateral neck dissection. Okay, now this compartment 2B is also known as compartment 2B. You can see here that this is a submuscular triangle. It is completely under the muscle, under the sternomastoid. So that is why it is known as the submuscular triangle. It is also known as the submuscular triangle. So you got the submental triangle, which is 1A, submandibular, which is 1B, submuscular, which is going to be your 2B. Okay, so all these three are the various triangles which are associated with the neck here. Clear? Right. So I will stop with this today. We'll continue the class tomorrow because it's already 10 o'clock tonight. I will stop with this. All of you have to go back and work as well. So tomorrow we'll have probably another 1 hour session at let us say at around I'm not sure of the time. I'll intimate it tomorrow to you guys. So either tomorrow or day after, because I may have an extended surgery tomorrow. So based on that, I will tell you. But we will have a discussion on the surgical aspect and the radiation and all that. That we'll finish it off in the next class. Another 1 hour class will be there and we can finish it off. Any doubts with regard to today's class that you have? Did you understand whatever is there to be understood? Any doubts with regard to today's class? Right. So I believe all of you got whatever is there. So tomorrow we'll have a discussion. I mean, tomorrow or day after, whenever I'm just putting it up, I'll put it up in the group and I'll ask you to share it. So thank you and all the best, my friends. HPV negative slides shown as EBV. T stage 2 centimeter. Okay, T stage I will just explain once more. Just remember T1 is going to be only this less than or equal to 2 centimeter should be the size of tumor. Less than or equal to 5 millimeter should be the depth of infiltration. This is T1. T3 is going to be more than 4 centimeter or more than 10 millimeter DOI. This is T3. Whatever comes in between these two is going to be your T2 tumor. Okay, T4A and T4B already know. Bone invasion, carotid, external carotid, internal carotid, masticator space, skull base, all this we already discussed. So what we need is the T1 and the T3. Okay, so that is what we need to have. So that is T1 and T3. All the rest will come under your T2. Okay, right. HPV negative and positive. So what do you mean by P16 positive? Essentially means it is HPV positive. Whenever you say it is EBV positive, it means it is a nasopharynx tumor. Okay, so whenever you have P16 or HPV or EBV positive, so that is when you will use the different nodal staging. What is that? N1 is ipsilateral less than or equal to 6 centimeter. N2 is N2 is going to be contralateral or bilateral and less than or equal to 6 centimeter. Okay, and then you have your N3, which is going to be greater than 6 centimeter. Okay, so yes, everything is No, less than 6 centimeter. Anything which is more than 6 centimeter straight away goes into N3. Okay. And other than that, whenever you have your RP nodes in your nasopharynx, specifically if you want to talk about it, so RP nodes will be grouped as your N1 nodes. And whenever you have a node beyond caudal cricoid, so that will be coming as an N3 node. So whenever you have a supraclavicular node, whenever you have a supraclavicular node, that will come under N3 node as far as the nasopharynx is concerned. This is a question that comes because supraclavicular node will be distal to the, it doesn't matter what is the size, it will be distal to the cricoid. It will be below the cricoid, right? So your level 4 will be distal to the cricoid. So whenever you have a distal node, that is going to be distal to the cricoid. So I mean, whenever you have a supraclavicular node, that is going to be distal to the cricoid. So in your nasopharynx, it will come under your N3 node. Clear? Right. Okay, friends. So that I think cleared all your doubts with regard to the T staging, the N staging, some of the investigations. These are common questions that keep getting repeated. So, right. Good night. And I just intimate the time of the next class, and we can wind it up with that class. Thank you. Hello. Yeah, yeah. We can conclude the session. We can stop it and yeah, we can close it.